Welcome everyone to this webinar session. We are glad that you could make it in time. I know that there'll be a number of people joining in as we continue, but I'm glad that you've managed to make it in time. We just want to first appreciate the panelists who have carved out some time of their busy schedules to share with us their learnings and their experiences. I'd like to introduce the webinar, and after that, I will just mention one or two words about the rules of engagement for this session. So this is the second in a series of PHC performance-related webinars, and we anticipate to do more once every month. But this time, we are very privileged to have three distinguished speakers joining us. We have Boniface Mbuthia, the Technical Director for Health Financing at Amref Health Africa. We have Dr. Joy Mugambi, the County Director of Health Administration and Planning in Nakuru County. And we have Dr. Charles Ndirangu, the Medical Superintendent at Mount Kenya Sub-County Hospital in Nyeri County. We are eager to learn about how financial management capacity is being strengthened at county and facility level. We are excited to learn about the best practices and the innovations that are in place, particularly with these new reforms around the FIF implementation process, and carrying on with the work around facility autonomy strengthening. So as a quick reminder to the audience, we have a Q&A window. So for any questions, we invite you to type them in on the Q&A box that's on your Zoom panel. We will be able to invite some of the participants to voice the questions, but we encourage you to continue typing in the question and answer, the questions for answering. The panelists will see and allocate which questions that they can answer live, but we'll also be typing in responses for questions that have been probably discussed in the presentation and so on and so forth. Okay, as we work on the technical issue with the first presenter, we want to invite the second presenter, Dr. Joy Mugambi, to take us through the lessons that we may learn from Nakuru County. Welcome, Dr. Joy Mugambi.
Thank you very much. Dr. Joy Mugambi, County Director, Health Admin and Planning, Nakuru County, and it's an honor to be here to share what we are doing as Nakuru County in terms of the progress made in FIF. As I load up that, the topic today is building financial management capacities for our facilities for FIF implementation. And I'll be sharing the Nakuru County's best practices and innovations. Let me start with demographics. Our total population is about 2.4 million. We've got the various parameters in terms of the estimated pregnancies, and this is as per 2023 statistics. But we know we are growing exponentially. At that time, we were at 2.4, and by the next census, we know we'll be way much further than that. Our health facilities are distributed. We've got the public and the private and faith-based facilities. In total, we basically have one level 5, which is a public institution, an admix of the level 4. We have 34 of them, 16 are government. whereas 15 are government, whereas the level 3 we have 79, where 43 are government. Level 2, 435 in total, both public, private, and faith-based, but 155 are government. The level 1, which is the community health promoters, we have 362 units. That translates to around 3,620 community health workers. Though they fluctuate because numbers come in, numbers go out, and but they range around 3,400 to 3,600. These are our sub-counties. We have 11 sub-counties: Gilgil, Kuresoi North, Kuresoi South, Molo, and you'll see how they interplay during our monitoring and evaluation of the performance of FIF as well as the primary healthcare indicators. So as a background, FIF for us was transitioned to the Department of Health immediately after devolution. So we did not go into a consolidated banking system. The facilities continued to receive and utilize their monies immediately after devolution. So the 15 years of I would say the 14 years of devolution, we've enjoyed utilization of facilities at the facility improvement financing at the facility level. And they retain 100%, they account for it, and user fees generated are used by each health facility to improve the quality of health services. So the guiding principle at the time of devolution was through a regulation that was derived from the FIF Act. We did not have an act of FIF, but we utilized the regulations, and we were able to indicate how to utilize the budgeting, the accounting, the reporting, the auditing framework were all outlined clearly within that regulation. Then there was also the framework for waivers and write-offs. At that point was when we did not have the SHA and SHIP. People were going through waivers and write-offs, and this was well outlined in the regulations. Then services that benefited the society in general were provided for free, like the under fives, which continued being served. They continued being served as free services. So we moved, at that time, the procedures were for NHIF claiming, but we've currently transitioned to the SHIF and SHA claiming strategies, and we are aligning with the mandate of SHIF and SHA as outlined. And banking arrangements were made through the regulations, including the opening, the operating, the closing of the bank accounts of each health facilities. Through these regulations, there were clear guidelines in terms of the committees, their functions, and they ensured that monies were accounted for and mobilized as per the requirement of the framework. So that's a brief in terms of our history. In 2017-2018, that was our FIF collection, and it continued growing within the facilities up to 2021-2022, where we had the 1.5. And, that's when now the reforms for PHC as well as the SHA and SHIF started coming in. And in 2023, we were transitioned into the SHIF portal and the facility improvement, the FIF Act as well as the PHC reforms. With that, we've had still an incline in terms of facility improvement collections, which have seen an upward trend. When you look at 2022-2023, we started off almost at the same baseline that we had in 2021-2022. But during the reforms for SHA-SHIF, we went down slightly to around 1.4. And then we've better accounting, better training of our staff, and improvement in terms of collection, as well as accountability of how monies were being collected and being reported for. We've come up in 2024-2025 to 1.7 billion. So what were these reforms in terms of health financing reforms within the county? One of the key things that really benefited us, we looked around and saw our level 2 and level 3 health workers and also the managers within the level 4 facilities were not very well trained in terms of budgeting and also accounting for the monies. And they were now receiving a larger amount than they had been receiving previously. So we engaged partners. We started out with training the level 4 and level 5s on program-based budgeting from the KSG. And we had a partner who really supported us in that. Later, we now started finance clinics. These clinics were held monthly, and also we had bigger forums during the quarterly meetings to go through formulating a budget, monitoring and evaluating, looking through various documents that they needed to utilize to ensure that proper reporting and proper utilization of their monies is done. We went through trainings of procurement, budgeting, stocking, which is the pharmacy bit, and non-farms, and we ensured that our staff are well trained. This has continued up to now. Various partners have come in to help us do the trainings for the level 2, 3, and level 4, 5. And currently we have each facility having its own facility budget. We are having now a PHC performance monitoring dashboard, which I'll show you shortly, which we have partnered with Hector to develop. And really that dashboard shows us quite a lot in terms of how finances are moving, HR, and flashes out where indicators are a problem. So this is a template of our facility budgets. Previously, we used to have budgets at the headquarters for the level 2 and 3s. The only facilities that used to make a tentative budget were the level 4 and 5s. But at the same time, they were not as good as they are right now. And also they are able to align not only the recurrence, but also their development budget. This is an example of one that we were doing last week. We've given them an example of what to include in their development budget. This was for level 2 and 3 facilities. They also have developments that they do, maybe repairs, construction, fencing, and these monies will be utilized from the FIF, which really helps them do developments that they would want. Then there is the recurrent budget. For those who wish to employ, they have the opportunity to include that in the compensation to employees. Maybe they want extra staffing and they would want relief of what they have, and they have some finances to be able to do that. They can as well include that in the budget. Then the normal operation and maintenance budgets, which follow through. So this is our dashboard. Just a glimpse of what we have done for the month of February. The facility health financing assessment is one of the indicators that we are tracking, but within that dashboard, it has various pillars that are being tracked. But I concentrated on the pillar of health financing. We've assessed 55 facilities. We decided to sample 5 facilities per sub-county, an admix of faith-based and private, as well as government facilities. It took quite a lot to get the private facilities to give data, but now they are on board and they are seeing the improvements that they can make when they work together and they monitor and track their finances. We've done 11 assessments. This coming month, at the end of this month, we'll celebrate 1 year of tracking of our progress, and you'll see the dashboards in terms of the progress made. So this is our performance trend in terms of performance analysis of the finances from February all the way to February 2026. The collections from the 5 facilities per sub-county, in total 55 facilities. And basically in Nakuru, we started at 77. There have been slumps. And one thing I keep saying, I think as the end of the year comes to be, people kind of tend to slow down and then they pick up when the financial year starts because the quarter, you can see there is a raise. And around November, when the next quarter is beginning, we have a slump. And as we move on to December, there is a lot of activity because an AIE has been released. Then we are back down. February, as the quarter is ending, we are seeing a downward trend. And we are looking at what we do about this because these upwards and downwards trends means even morale is low when there is no financing, and probably also work dips at that point. But these are the things we are tracking to ensure that we don't have those dips and we improve also the claims within their AIs so that they maintain an upward trend. This is the dashboard for February for our sub-counties. We have 11 sub-counties. This is Nakuru East, Nakuru West. We've got Nakuru North, Subukia, Kuresoi South, South. Oh, sorry. And Kuresoi North. Then Gilgil, Molo, Gilgil here is red this month, and we are tracking to see why they ended up with a red dashboard on around their financing. But one of the things that also brought these reds was we were transitioning to the Taifa Care, and reporting was quite slumped in some of the sub-counties where transition took its time. So these are the components we were looking at: financial tracking, both for government and others, the SHA claims, SHA contracting, and you can see the trend from February 2025 all the way to February 2020. We've seen improvements. We've also seen downward trends, and we are monitoring to ensure that we turn green in total, and not just for the public facilities, but also for the private facilities. We are evaluating why this happened around this month. There was a lot of traction to ensure everyone is on the SHA contracting portal, as well as their revenue for the private faith-based was improved. Whereas we also had a challenge in terms of our revenue tracking, but we had a good SHA contracting numbers as well as claims. So as facilities also increase, we see contracting also needing to increase. So you'll ask why 95 was while we were at 100. We've got new facilities coming up, and some of them may not have renewed their contracts. Some may have been withdrawn because the names had changed, and we've had quite some challenges in some of the facilities, but we are working to ensure we improve that. So these are dashboards. With anything, if you want to start your journey, you need to monitor your dashboard and ensure that you have enough fuel, you're at the right speed, and going to the right direction. And we really thank Hector for having developed for us this dashboard. I'll share this link. I'll click this in a while so that you get to see as we move on to the next slide. Allow me to change that to this dashboard. I would really want you to see how the dashboard looks like so that you get to see what we are enjoying alongside the good work that's being done by our partner. minutes there. I hope. So these are dashboard. It does not only carry information for revenue, it's also tracer drugs, HR presence and ratio. We are somewhere good. Our HR presence and ratio is around 100%. The dashboard now looks better than it started in terms of HR. Tracer drugs keep changing based on the month, but our revenue track has its own ups and downs, which we also keep monitoring and tracking and alluding to the challenges that come up and also talking to each facility as they move on. We soon will be transitioning to include other facilities, but first we wanted to study the system to be able to understand it. When you come to the dashboard here, you can change the month. That was August, and be able to see the trend that was there. That was August. We had more reds within the sub-counties, and the trend per sub-county can also be tracked from the dashboard. If you want to note what was happening in Gilgil, you can come to the dashboard on one corner here and select Gilgil and apply the filter and be able to tell what is happening with each of the facilities. So we can see Gilgil started well in February, had a nice peak around June of 2025, went down in July. And this is a trend with most of them when the quarter goes down, and especially at the end of the financial year, we noted that trend. December 2025, people were very active. It was the second quarter, money had been disbursed, and you can see the trend was working out. Now, second quarter, this is where we are, and that's why the red in the second quarter. So we are able to track, we are able to see, and we are able to offer first aid where necessary, and also work with the teams to be able to improve reporting and ensure we monitor and track. I'll pull this down. The dashboard is available. I believe Hector team can support any other team that's willing to work with them to get a similar dashboard. I'm almost done, so do not worry. So what have we learned from these reforms that we've had? We've learned that ring fencing of FIFs leads to introduction of newer service in hospital service menus, and this has really helped to improve most of our facilities. Even the health centers and the dispensaries, some of them make quite a lot of revenue from their facility improvement. We've got dispensaries, health centers, which are even making more than some of the level 4s. The department has also witnessed an increase in revenue collection from these health facilities, which helps to have them improve. And it also helps with maintenance of infrastructure and ensures that equipments are functional, serviced, and available on time. We have been able to support also short courses and development trainings. KSG trainings are done through the IFIF, and staff are able to leave whenever the resources are well planned and scheduled. Then there is timely payment of suppliers. And with this, we have seen for our success to be possible, we've had good executive and assembly support, which is the key ingredient of success, because within the three devolved functions, they've maintained having FIF within facilities, and this has seen the improvements within our facilities getting better. We've learned lessons that financial autonomy also leads to accountability. It's one way of gauging a good manager. We know if you have a good manager who knows how to manage finances, they'll improve their facility. And we've been able to witness that with people having the autonomy to manage their money. We've also seen lessons that we've also learned is that automated modern systems, our revenue collection has an automated system with a dashboard that managers can see their money coming into their accounts. With one unified M-Pesa payment system that actually is easy, because even if you're outside the country and your mother is at the waiting bay, you can pay from wherever you are, even from another county, to be able to have them access care if they are on out-of-pocket payment. And if there is anything that needs payment, you can use that one M-Pesa model. But now with FIF and SHA, we are able to ensure that everyone gets services. We've also had the opportunity to ring-fence FIF that ensures payment of huge bills, like the KEMSA bills, which now ensure supplies are maintained. When there is emergencies, at least facilities have money and access to be able to sort out their emergencies. So we want to thank our partners, Hector Consulting, for the good work that we've been able to do. Amref Health, we've got a lot of collaborations in different aspects, especially the primary healthcare reforms and trainings. Finance Alliance has helped to ensure that we have sound budgeting trainings performed within the county health management as well as hospital management teams. And Thinkwell as well has been able to offer us technical support. ID Insight has been there with us to ensure we also get to learn quite a lot in terms of health financing, health management, and tracking. And Japaigo started the clinics at the very early years of 2022-2023 and enhanced them as we moved forward. One thing we have learned, if you want to go fast, go alone. But if you want to go far, you go together. And that's why working with partners has really been key, bringing them together and having them talk to each other and blend their activities to ensure that you have the best in terms of implementation of your work. So thank you. Karibuni Nakuru, and come learn from us.
Thank you very much, Dr. Joy. And I see already there's a question that we will pose to you at some point. But first, we would want to invite Dr. Charles to also share the experience with the Nyeri County and particularly with Mount Kenya Sub-County Hospital. So let me invite Dr. Charles Ndirangu. Thank you very much.
Thank you, and good evening, everyone. And as I've been introduced, my name is Dr. Charles Ndirangu, the Medical Superintendent, Mount Kenya Sub-County Hospital in Nyeri. I will quickly give a brief overview of what of the landscape of Nyeri County, because as opposed to what Dr. Joy has presented, I want to present FIF implementation status from the perspective of a health facility as opposed to the perspective of a county. Just for you to be able to better understand how our hospital is, Nyeri County is a county that is much smaller than Nakuru in terms of population. Our population is around 750,000, and it has we have 8 sub-counties. In terms of the public facilities, we have got one, and in this case, I'm talking about the ones under the county. We have got 1 level 5, that is Nyeri County Referral Hospital. We have got 6 level 4 hospitals, and we've got 100 and and 3 level 2 facilities, and 23 level 3 facilities. As you may be aware, Nyeri County was one of the counties during the UHC piloting program, was one of the counties that were selected amongst 3 others, that is Kisumu, Machakos, and I think Isiolo. And Nyeri was selected because of the high incidence of non-communicable diseases. And this was around 2018 to around 2021 or thereabout, if I'm not wrong. So in our case, as opposed to Nakuru, who've had a very long time since devolution of implementing FIF. In our case, there was an interruption by the UHC program, meaning that our clients were getting free services from all our facilities. That was from 2018, 2019, I think sometime 2020. And at the end of that piloting program, Nyeri County Assembly enacted into a law what we call Nyeri County Health Services Fund of 2021. It's actually an equivalent of the FIF Act of 2023 at the national level. But what stands out from the Nyeri County Health Services Fund of 2021 is that it had foreseen what we are now doing as a country, and this is shifting our gears and shifting our focus to promotive and preventive healthcare. This is concentration on primary healthcare. So after the UHC program came to an end, facilities now began collecting their own revenue, and they were retaining, as I will show you how we've been retaining, because in our case, for Nyeri County, it's not 100% being retained at the facility level, but it is 100% at the department level. This will be the outline of my presentation, and this is an excerpt of the regulations of the Nyeri County Health Services Fund. So how it works is that, remember, previously our dispensaries and health centers were not charging; they were providing free services, meaning that by the time that is after the UHC program came to an end, it's only the level 4 and the level 5 hospitals that was charging. I think the health centers were just charging something small for the what you call the card. So for the level 4 hospitals, out of every 100 shillings that we collect, 3 shillings were being set aside as administrative charges for or fee for a fund board at the county level. We call it Nyeri County Health Services Fund Board. This is the fund. This is a board that administers over all the revenue that is collected by the facilities, and this is in a bid to strengthen oversight and governance. Out of the remaining 97 shillings, 20% of it from all the hospitals is retained for primary healthcare services, meaning that for every 100 shillings collected by the hospitals, about 20 shillings will go to support the health centers and the dispensaries in the county. And as this 20%, in our case, has also been a particular proportion of it has been supporting our ambulance services to make sure that we are enhancing and we are strengthening our primary healthcare services. Of course, this landscape might change now that the facilities are collecting, the dispensaries and the health centers are now collecting money from Social Health Authority, that is from the Primary Healthcare Fund, the capitation. Probably this might change now because they are also able to collect some money, but this is a discussion that I'm sure will proceed. But of note is that 100% of the revenue within the Department of Medical Services remains within the department, and we've not been doing any cash collections. All payments are made through M-Pesa, and others can also make payments through bank transfers. So to summarize how our act has been working is that hospitals retain 77.6% of the collection. So what are the provisions from these regulations, from this act? What can the hospitals do? What can Mount Kenya Hospital do with the amount of money that we retain? So number one is purchase of basic medical supplies and equipment, purchase of some specialized materials and supplies, wages for temporary employees, these are the casuals, and operations and maintenance, and of course, patients' foods. So everything else is supported from the Department of Health budget. Just to draw a picture of how this fund has grown, Ours began, as I said, in 2021, 2022. And at around that time, for the first year, I think all our hospitals collected around, I think around 300 thereabouts. These are rough estimate, 300 million Kenya shillings. And in the last financial year, that is 2024, 2025, we had improved this to almost 800 million, I think almost 800 million. And in this financial year, we are targeting to collect 860 million. And we hope that by next year, we'll be able to grow our fund to at least 1 billion, which we have actually achieved if only we are able to get all our investments being done from SHA. So in terms of budgeting autonomy, how much autonomy does the facilities retain? In Nyeri County, and specifically in now for Mount Kenya Hospital, at the end of, we do an annual budget at the beginning of the financial year that is prepared by our hospital from the feedback from the HODs and the HMTs. Then an annual budget is prepared, a procurement plan is prepared, and then based on, in terms beyond the annual budget, every quarter we'll be doing a quarterly budget. For example, in this quarter, once we close this quarter at the end of this month, our executive expenditure committee at Mount Kenya Hospital will sit down and prepare a budget proposal. So this budget proposal will be presented to our hospital board that sits at least quarterly, and it will discuss this budget. This budget proposal will then be presented to the Nyeri County Health Services Fund Board at the county level. And in this board, we have members of the community. We've got the chairman or the chairpersons of some of the level 4 hospitals, and from the level 2s and the level 3s, to make sure that we've got representation from the full landscape. And once this budget has been approved and their input has been given, and I would call it input because it's not directive, the boards, both the hospital boards and the one at the county level, they give advisories on what they think can be done or how the hospitals can improve their budgets. And then the hospitals have got the final say, after which the chief officer will issue the AIE to the medical superintendent, with myself now in the case of Mount Kenya Hospital. How are we controlling our expenditure? We run an electronic vote book system that tracks all our vote heads in real time. And we've ensured and we've strived to ensure that we do not do any purchase, any procurement that is not supported with a budget or without a proper requisition being done. We also do monthly bank reconciliations to be able to track how we are collecting our revenue, how we are spending. And we also do quarterly reporting to the M&E unit, that's the monitoring and evaluation unit at the department level, reporting how our revenue collection is vis-a-vis our annual targets. So who manages the finances at Mount Kenya Hospital and what are their roles? I would call this the financial management team at Mount Kenya Hospital. We have the medical superintendent, the administrator, the hospital account, the procurement officer. We've got the revenue clerks because of their role in collection, and the heads of department. And as you can see, these are the different roles. The medical superintendent, as per the FIF Act and also the PFM Act, is the accounting officer, which is a delegated role from the chief officer. And I'm in charge of overall oversight and approvals of anything to do with finance within the facility. I may not go through the responsibilities of every other officer, but as you can see, the administrator assists in day-to-day administration of finances, reconciliations and budgeting and monthly reporting, financial statements, the accountant. We've got the procurement officer ensuring that we are adhering and complying to the PPDA, and that we are also maintaining a proper system that tracks and how we are managing our suppliers. And to summarize the role of the medical superintendent for Nyeri County at the hospital level, by and large, we are guided by the PFM Act, or the roles of the accounting officers per the PFM Act. And on top of that, we institutionalize internal controls to prevent financial fraud, to ensure that there is value for money for all the procurements that we are doing. And very important is that since the medical superintendent is the secretary to the hospital board, we provide the technical support to the board to ensure that the board is able to administer its oversight role effectively. So in terms of capacity of our boards and capacity of our staff, and also in terms of governance, I mentioned that we have a board at the county level that is actually gazetted. You've got boards at the hospitals, and these are constituted from the members of the community, and they are vetted by the county assembly, and as well they are gazetted. At the facilities, the level 2s and level 3s, they have gazetted members of the facility management committees, and these boards all of them have undergone induction, and they have been sensitized on financial management, again to strengthen their oversight roles. I mentioned earlier that they have a role in reviewing and approving of the hospital quarterly and annual budgets, as well as the procurement plans. And all the level 4 hospitals are, for the level 5 hospital, that is the county referral hospital, their chairperson sits in the Health Services Fund Board. But for the level 4 hospitals, we are represented on a rotational basis. So at a particular time, we'll have the chairperson of Mount Kenya Hospital sitting the board. The next time we'll have the chairperson of Mukurweini. The next time we'll have the chairperson of Narumuru. That's how it has been operating. We get good support from the CHMT. And case in point I want to bring out is that Nyeri County operates what we call a procurement hub at the CHMT. So we have got cutoffs for level 4. This is how much you can go in terms of procurement. Anything beyond that, where it has to be supported from the procurement hub. And this has actually, for some people, there are those people who may look at it as a bottleneck. But another angle to look at it is that there are some, at the hospital level, the procurement officers at the hub are able to build capacity because they have been assigned some hospitals to support. So whatever expertise you may lack at the hospital level, and even at the level 2s and level 3s facilities, they're able to get this support from the procurement hub. And we also, in our department, the department maintains an open door policy between the hospital officers and the CHMT members, and this is to encourage and promote consultations. For our accountants, all our hospitals have got accountants, resident accountants, and all of them are in good standing with the ISPAC. And in our case, for example, Mount Kenya Hospital, we support our accountants to ensure that they've got the CPDs, to ensure that they are always in good standing with the ISPAC. We have our procurement officers have undergone through trainings. Same case for our revenue clerks, especially on claim management, how they are supposed to submit. But we're hoping that now that we have rolled out Tibabu, which is a web-based HMI system, we'll be able to automate our billing system. We've also, our pharmacists, the ones who are in charge of ordering of drugs, our nurses, especially the ones who are in charge of the non-farms, have undergone through stock management just to improve their effectiveness and on how they are forecasting and how they are assisting the hospital to forecast in terms of commodities in our hospitals. In terms of leadership and what I'm calling weekly learning, recently, the department is having bi-weekly meeting between our accountants and the revenue clerks to be able to track how we are doing in terms of claims to the insurances, and especially claims to SHA. We've had our managers going through trainings and supported by our FIF, SLDP, and senior management. And very importantly, every quarter, all the top hospital managements, together with the sub-county teams, hold a quarterly managers meeting. And in these meetings, there is always a session that discusses financial management to strengthen the capacity of these officers. In terms of financial management, so which system do we have at Mount Kenya Hospital? I said that we run an electronic vote book. Our revenue collection is through M-Pesa, direct bank transfers. I don't want to dwell much on the SHA claims portal because this is standard. We operate one bank account, and this ensures transparency. And I mentioned about the weekly reports to the M&D unit. Of note is that we do not use IFMIS at the hospital level. This one is applied at the Department of Medical Services. In terms of ensuring compliance and adherence to the PFM Act, number one, we ensure that we are doing monthly bank reconciliations, the weekly reports that we are making to the M&D unit. We also do the quarterly financial statements submitted to the Office of the Auditor General, the annual statements that we present to the Office of the Auditor General. We also have a target in the performance contract that at the close of the financial year, we are supposed to make sure either we have 0 pending bills or if there's a pending bill, they have to be less than 0.1% of our budget. And I'm happy to report that in our case as Mount Kenya Hospital, for the last 3 years consecutively, we've not had any pending bills at the close of the financial year. And we also do regular monitoring of our vote book balances. And this is to ensure that we are absorbing the budget, and we're also actually paying our suppliers. We're also very happy that for the 3 exercises we have been audited by the auditors from the Office of the Auditor General, we've had qualified opinions, and we are really looking forward that the next one will be able to get the best opinion, which is an unqualified opinion. This is just to show the results of from Mount Kenya Hospital. How have we been doing in terms of revenue collection? There's something I forgot at the beginning of, or when I was introducing my presentation, that when COVID came, Mount Kenya Hospital was serving as the isolation facility for the county, meaning that when COVID came to an end, we were subject to a lot of stigmatization, and we had to do a lot of work to destigmatize our facility and to encourage clients to actually come and consume our services. So as you can see, in terms of our revenue collection, from 2020 to 2021, we didn't have a target because remember this was during the UHC. But when the UHC ended, we only managed to collect 3.9 million, which increased to 15 million the next year to 17 million. Because Mount Kenya actually is a very small hospital. I should have mentioned this. In 2023, 2024, we collected 29 million, 29.5 million, which was an improvement of more than 32% compared to the previous year. But we dropped in the last financial year. And I'm sure you guys could be as good as mine, that this was the year when, from October of 2024, SHA came into place. And we had challenges in terms of reimbursement of claims, because if you compare how much we had, all our claims and vis-a-vis what had been paid, you'll actually realize that we had collected more than what we had collected in the previous year. You can also see it in terms of the various insurances. I may not be able to dwell on that. We've also had we also had challenges with our waivers. This was before SHA came. But after SHA, that is 2024, we've seen a considerable reduction in the waivers, meaning that actually SHA could actually be providing a very good cushion and from what we call a catastrophic healthcare expenditure for our clients. And this is just to show revenue collection by source. If you look at the orange one, and I hope I'm getting the color right, more patients were paying by M-Pesa, which is actually an out-of-pocket payment. It was almost the same even 2024. But if you're able to present what you collected so far, we have got very minimal collection from M-Pesa. Currently, almost all our revenue is coming from SHA. That was the message I wanted to bring out from this presentation. And in those 5 years, in total, we collected around 89 million for our hospital. Of course, the biggest challenge we're having, we also got a very significant proportion of our revenue that has not been, claims that have not been reimbursed by the Social Health Authority. In terms of our allocation to HPTs, this is also something very controversial. We have got, from our chief officer and from the Health Services Fund Board, we are encouraging facilities to allocate more and more incrementally to health commodities. In fact, our target is that 40% of our budgets should be allocated to health commodities. This to supplement what the county has been allocated to the hospitals. I know some people may argue that the FIF Act of 2023 stipulates that under retention, the facility collection is actually supposed to be a supplement to the resources from the county assembly. And this is why, for us to comply to this is where we are trying to encourage more and more of our hospitals to allocate 40%. In our case as Mount Kenya, because of competing needs, operations and maintenance, sometimes you are able to achieve I think we only achieved once to hit the 40%. Other times you are raising at around 35%. Some bad quarters we are at 20%. But I think the last budget that we did, we are at around 35%. And hopefully the one that you're going to do next week, for the collection you've had for this quarter, we are optimistic that we'll be able to allocate at least 40% to our budget. Of course, our other biggest spenders as Mount Kenya Hospital is electricity bills, water. We've got some number of casual workers, which we have managed to reduce over time. patient food, and of course, refined fuel. I think this is the last slide where I want to present what are some of the achievements that we've had as Mount Kenya Hospital under the FIF Act or under the Nyeri County Health Services Fund. Number one, we've had a number of projects as Mount Kenya Hospital funded by our own revenue. For example, installation of CCTV, surveillance cameras. We've supported a number of officers for short courses, SLDP, SMC. We've had a number of, to motivate our staff, supporting our staff to go for conferences, team building activities. And the fact that you also maintained no pending bills at the close of the financial year, this is actually an achievement for us. We've also noticed that FIF incentivizes efficiency because for all the officers at the hospital, once you know that if you collect more, you actually also start to benefit because you're able to improve the work environment at the hospital. You start to benefit from either being supported for a conference or a short course. We are seeing now our officers taking interest in assisting the management to improve revenue at the hospital. Another good practice is that Nyeri County currently, we start at 70% in terms of share registration. I think we are at position 5 nationally. And we've been doing a lot of drives, even without partners, supported by the Department of Health, and to make sure that more and more of our people are registered under SHA. And we are starting to see these fruits in terms of PHC capitation. We have also have a waiver guideline from the CEC of the County Treasury and Finance to guide on how hospitals are supposed to apply waivers at the hospital level. We've got strong internal controls, and what I've talked about, our PC as the medical superintendents requires that we ensure that we have pending bills at less than 0.1% at the end of the financial year. We've got advisories coming from the fund boards without necessarily interfering with the autonomy of the hospitals. The bi-weekly meetings, the weekly revenue monitoring presentations or reports. We have also had very good, we've had qualified opinions from the Auditor General, and we are optimistic we'll be able to get a qualified opinion in the next audit. So what are the key challenges that we are having, or as the medical superintendent I'm experiencing at Mount Kenya Hospital in terms of implementing SHA, or implementing Facility Improvement Fund? In my opinion, the biggest challenge is delayed reimbursements or unpredictable reimbursements from the Social Health Authority. Pending claims of 13.5 million for Mount Kenya Hospital, being a small hospital, is actually significant, and this strains our cash flow. It strains how we are able to provide services to our patients. We're also having challenges with claims being rejected, and this is why we are having the bi-weekly meeting between the accountants and the SHA clerks to improve this. And we are hoping that now that we have rolled out Tibabu, it will automate all these claims. We have staff shortages, and this staff shortage is not just in the revenue department or accounting department. The fact that we lack some service at the hospital means that we also have to refer these patients to go and access this service elsewhere. And any patient referred elsewhere, that is revenue lost. We have missing clinical services. I've mentioned about that. We also have a significant proportion of waivers because you have some patients who are not registered with SHA, or they are registered but they're not paid up. So once you manage them in the wards and you're discharging, these patients actually cannot pay, and you end up waiving and losing revenue. And tied to this is patients who come, especially from areas that are other counties. We're having patients who have got no national IDs. These are adults, making it a challenge for us to register them under SHA. And this one is just to trigger our thinking that there could be a policy misalignment between our Nyeri County Health Services Fund or our version of the FIF against in comparison with the National FIF Act. However, in our opinion, it is actually just a divergence of views. It is not a contradiction, because actually the National FIF Act of 2023 allows counties to come up with regulations on how they will implement the FIF Act. But I know this is an issue that is being handled at a higher level, and we'll be able to get guidance on how to proceed about this. In conclusion, Mount Kenya Hospital has been more than ready. We have actually been operationalizing FIF, and we are looking forward to growing collecting more and more from our own source to make sure that the hospital grows from the facility that was just known as an isolation facility to a hospital that is able to provide more and more services to the people of Nyeri. Thank you so much for your attention.
No, thank you very much to Dr. Charles for that very interesting and insightful presentation around how the facilities are building the capacity and also adopting a very interesting learning method based on the activities that they're doing, based on deliberation across different departments. Really good to learn about that. I understand there are quite a number of questions that have emerged from this. So before I invite Dr. Boniface Mbuthia to give a word or two, just wanted to highlight two questions, one for Charles and one for Dr. Joy. For Charles, there was a question around the provision of well, the carving out of 40% for HPTs from the FIF collections. In this case, just to clarify, do you have preferential sourcing for these HPTs on where the county has sourced, or do you choose your own sources? And then a question for Dr. Joy about of these implementation of FIF to improved services, more accessible services. Do you have any information from client satisfaction reports to validate this kind of finding? Then after that, we will pass it over to Boniface to give sessions 2 as we come to the end of the session. So a question for Dr. Ndirangu and a question for Dr. Joy. Thank you. So over to you, Charles.
Thank you. On the question on how we source our commodities, our main supplier for commodities is KEMSA. But as you understand, KEMSA has been having the order fill rate for KEMSA has been quite low, but I'm sure something is being worked on to improve the order fill rate. So for the first port of call, whenever we are making any order for HPTs, is KEMSA. And for whatever is not available in KEMSA, the next place that we source for in our case for Nyeri County and for Mount Kenya and Nyeri County is MEDS. For whatever is not available in MEDS, whatever is not available in KEMSA, then we are allowed to go the quotation way, where we float quotations, and then you get bidders and they supply for you. But you also have another arrangement, especially for the lab commodities, where we have some equipment on placement. So for the equipment on placement, there is a provision for what I would call direct procurement. So you order the commodities from the companies or from the suppliers who have actually been allowed to place the equipment in our facilities. I hope I've answered the question.
Thank you very much for that. And over to Dr. Joy.
For that question, in terms of customer satisfaction, we embarked on a customer satisfaction in 23-24, but when the USID reforms came in, that was halted, and we now have moved on to a new partner. We have commenced doing a customer satisfaction survey with Amref, and we will be sharing a report by the end of the year. Though at the end of the day, when you look even at the utilization of services within our facilities, the numbers that come in are really huge, coming from very far, all the way from all our other sub-counties and within East Africa. And that tells you it's the service that drives them to come to us and be able to utilize the services.
Thank you very much, Dr. Joy, for that. We look forward to the findings from that assessment. As we come close to the end, and as I bring in Boniface from Amref Health Africa, just to mention that there's a question from Dennis around FIF and its effects on increased out-of-pocket expenditure. And I think that has been addressed by Dr. Ndirangu when he showed the flow of funds and showing that as SHA came in, actually that's tended to reduce the proportion that comes from out of pocket. Also, just to note that there was a question for Dr. Ndirangu around the reimbursement delays and how the county responds to these delays, provisioning, and so on and so on. I think you had mentioned that. How the county treasury, through the fund, are able to provision and ensure that services are still being offered, even as you are investigating about the rejection rates and so on and so forth. So I'd like to invite Boniface Mbuthia for a few remarks, even as we come to the end.
Great. Thank you so much, Peter, and thank you so much, Joy and Charles. Some great work. I just wanted to share just this one slide that I'll not talk too much about, but I just wanted to show us the journey we have taken. And just to say that in the 1960s and 70s, there was very little revenues that were being collected at our facilities. And those days, I am told that there were even no accountants in many facilities. And so people depended mainly on very input, based kind of financing, where if you needed gloves were supplied. If you needed healthcare workers, they were supplied. And NHIF then only took care of former employees, and they had very little premium. And so it was not attractive to facilities to be able to engage. And then when we come now to the 80s and 90s, things happen more or less like what has happened with Trump. And suddenly no money available, or rather the funding for health sector reduces. There's an increase now of private health insurance. There is a beginning of discussions around reforms on NHIF, and suddenly better benefit packages, and suddenly the resource envelope that is entrusted to NHIF grows. And then when we come to the 2000s, again here, we find now NHIF is able to now, grow to be a bigger player. And we can see that even the country attempts a different form of financing in the UHC pilots. And in the 2000s, again, more reforms on health financing that begin now to champion more towards the use of prepaid mechanisms as reliable payment mechanisms for health facilities. And I just wanted to bring this up because of a few thoughts that have come as we went through the session. And I wanted to start at the point where one of the participants asked about how the FIF would be able to help check out-of-pocket payments. And I think here the real issue is how facilities then would be able to see SHA as a bigger opportunity. Thinking through together, SHA controls about or slightly more than 100 billion. And these funds have not yet been fully optimized within our health facilities, particularly the public facilities. And I think we should see it as an opportunity more than it is a problem. And so that even where there are challenges like delays, I think we engage our counties to see how they can engage so that eventually we can be able to access the large pot of resources that are within SHA. And that eventually, as we get more people registered, as we get more funds being accessed through SHA, then we can be able to, reduce our reliance on out-of-pocket payments. The second thing is to remember that our public facilities can actually be able to offer services to private health insurers. And I think at the last count, I saw that the private health insurers have slightly more than 49 billion. And a lot of those resources are not coming back to our public facilities. And I think that's another opportunity. So if you add the 100 billion and you add the 40-something billion, there's more resources that facilities can be able to get. But what did I hear from the session? It was really exciting to listen through to both Joy and Charles as they described the different processes that they are implementing in their respective counties. And if I was to start with Nakuru, Joy presented the dashboard, and I think that active tracking is a good place to start because it helps the county managers to know what's happening in terms of revenue, to know areas that they can be able to support, to reach out to facilities in ways that they can be able to even build capacities, especially where they note that they are not able to get the resources that are needed. The second thing that the tracker then does is also it provides opportunities where you can be able to showcase what one facility is doing to another facility, and that way they're able to exchange, information. And I like the fact that you are able to see the tracker and get to see the progress, over time. Coming back to Charles, I was really fascinated by the active, intentional process that the facility and the county has also adapted in building the capacities of their healthcare workers, particularly in ensuring that they can be able to optimize, the FIF collections. I was really happy to know that you're going a step further to even train pharmacists and all those different people who give support, provide accountants, establish procurement hubs, ensure that bank reconciliations are done. And I'm sure there's also some place you also do some claims reconciliation. And the last one that was really exciting for me, the zero pending bills as a target, that even goes to some contracting, such that it could either determine continued support or not, and the reporting processes. So, and what this then helps us to understand is that first, it is possible for facilities and county governments to be able to optimize the resources that are within the SHA system. Number two, it is possible for counties and health facilities to be able to participate in the broader health systems agenda of ensuring universal health coverage, that universal health coverage is made a reality in our different settings. Because Nyeri and Nakuru provide very good examples of active engagements that are ensuring people are registered, ensuring that claims are being raised, and that claims are being followed so that reimbursements can be made. Out of all this, what do we learn? We learn that we can improve how we finance our facilities using mechanisms that are already provided for us. But I wanted to leave us with a challenge. Many times, when we think about facility improvement fund, we tend to think about that once we go through the facility improvement fund way, that this little resource, that as long as the resources are little, we can entrust the facilities to be able to handle. But when they become bigger, then we have to get another mechanism of helping the facilities to be able to manage. But what I see in the two examples of Nakuru and Nyeri, I see an opportunity where by facilities being able to build their capacities to be able to manage these resources, particularly those that come from SHA and other sources, it helps them to be positioned to receive more resources from the county, etc. And in that way, we can then be able to change how we offer services to our people, ensuring that when people come to our facilities, they get the best of care. And I think for me, that's one lesson that I'm able to take from this session. This session has been able to prove without doubt that there is something a county can do, there is something that a health facility can do to ensure that that finances that are meant to go to health facilities get to the facilities, and that facilities can be able to respond in kind by ensuring that they're able to provide the needed services that will be able to demonstrate quality and the highest technical standards that our people deserve. And so for that, I'm really, really excited to have participated in this session. I can't wait to be able to get the client satisfaction survey so that we begin to see how then do we intermarry the feedback from clients, the capacity in our health facilities, and ensuring that there is movement forward in terms of delivering better health services for our people. Thank you so much. And this is really one exciting evening for me and for all of us.
No, thank you very much to you, Boniface, for that summary and that interesting parting shot concerning what happens when the resources increase. We just want to thank all the presenters once again, and appreciate your time, and thank you very much to the attendees for sitting through the presentations and for the interesting questions that you've raised. We hope to see you in the next webinar next month, where we intend to speak about leadership and governance. Thank you very much, everybody. Have a good evening, have a good night, have a good afternoon for those who joined from other countries, and we'll see you. Thank you very much, everyone, and have a good evening. Bye.
Thank you.
Bye. Thank you.
Bye.
Goodbye, everyone, and good night.
Thank you.